Okay, can you see my slide?
Yes.
Okay, very good. Actually, basically for this afternoon, I have two lectures as mentioned by the chairperson. We start with the neoplasia, and the second part is the diagnostic histopathology. Okay, so we go for neoplasia first. Okay, for this is a lecture outlines for neoplasia. Basically, I will cover about the definitions of neoplasia and the nomenclature about neoplasia. What these are the most important things that you need to know. What are the characteristics to differentiate between benign and malignant neoplasia? A little bit about the carcinogenesis, and last one, clinical aspects of neoplasia. Okay, we look one by one. Okay, when we after that we will discuss further about neoplasia. Okay, before that, we need to know what are the definition for neoplasia. This is the full definition of neoplasia from the textbook. Okay, basically, neoplasia is an abnormal mass of tissue. Hold on. Okay. Abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissue and persists in the same successive manner after cessation of the stimuli which evoke the changes. In other words, or the simple words, neoplasia meaning new growth. Okay, that's the simple definition for neoplasia. Okay, in the neoplasia, they have the neoplastic cells. Basically, this neoplastic cell arise from the clonal, one clone. Clonal meaning is arise from a single cell that have the genetic changes or genetic damage. It's a difference from the normal cell, which is a polyclonal, meaning that in the normal cell, it doesn't have any genetic damage. Okay, in neoplasia, okay, when we say neoplasia, actually they have two broad categories. Okay, it includes the benign tumor and malignant tumor. So meaning when somebody said neoplasia, it doesn't equal to a carcinoma. Okay, so when we say neoplasia, it include the benign and malignant tumors. In between benign and malignant tumor, they have the precancerous lesions. Okay. So benign neoplasia, they have few characteristics. The first one is gross and microscopic characteristic relatively innocent, or for benign neoplasia, they have a capsule or localized, so that the basement membrane in the benign neoplasia still intact, so it cannot spread to the other side adjacent structures or other organs. And the other features is when we remove the tumor, it's completely cured, so patient will survive. How about the malignant neoplasia? Because of the malignant neoplasia, the membranes already disrupted. It can cause invades or destroy into adjacent structures and metastasize to other organs. Okay, that's the difference between benign and malignant neoplasia. Okay, for both benign and malignant tumors or neoplasia, they have composed of two basic components. Okay, the first one is a parenchyma, which made up of neoplastic cells, and the other component is a reactive stroma. It's composed of connective tissue, blood vessels, and all the inflammatory cells. Okay, this is a little bit about the nomenclature, meaning how we give name for the tumor. Okay, just now you learn about the tumor or neoplasia. We divided into benign and malignant tumor, right? But then each of the tumor, actually basically we can divide further according from the arising cell of origin of the tumor. Okay, in the big group, we can classify tumor into mesenchymal tumor, meaning mesenchyma is the tumor arise from the cartilage. Epithelial tumor is tumor arise from the epithelials. Lymphoma is tumor arise from the lymphoids. Okay, so for the mesenchymal tumor, is tumor arise from the cartilage. For example, if the tumor is arise from the cartilage, okay, we just add the words oma at the end of the arise of the tissue. Okay, so for example here, chondroma. So we add on the words oma. So meaning when we say chondroma is a benign tumor arising from the cartilage. Okay, so mesenchymal fibroma is a tumor arise from the fibrous. So we just add on the words oma here. Osteoma is the benign tumor arise from the bones. How about epithelial tumor? Is similar also. We still add on the words oma, but a bit different for epithelial because we give name depending on either histologic finding or morphological features, meaning that for the first category, when we see tumor, when the tumor cells is forming glandular structures, so we give name as a adenoma. Okay, papilloma meaning the tumor is forming the papillary structure. Papillary structure meaning that they have the fibrovascular core in the middle and lined by the epithelial cells or tumor cells. Okay, papillary cyst adenoma meaning that this tumor have the cystic component plus the papillary structures. Okay. It is examples. So this, I think you're really familiar with this specimen. Okay, this is a colectomy specimen. We can see here this polypoid lesions. Okay, so when we look under histology on microscope, okay, what we see here, this is the normal colonnade tissue. This is the polypoid areas. Okay, that's similar what we saw in the gross specimen. So when we saw this, okay, this is a polyps, okay. So we need to identify this polyp, is it benign or malignant? So when we look closer, okay. Okay, sorry. Before that, when we look here, we cannot see any invasions, okay? Because when we want to say malignant tumor, we must see the invasions. But for benign tumor, there is no invasion. So meaning this the adjacent normal colony issue doesn't have any infiltrations by the dysplastic cell. The dysplastic cell only occur at the surface here. Okay, so this is a tubular villus adenoma. We need to look closer for grading into low grade or high grades adenoma. Okay. Next, this is a specimen of the bone. So in the middle here is the tumor. You can see here on the gross specimen, the tumor is well circumscribed. The age is well defined margin. Okay. So by looking at the gross specimen, we know this is a benign tumor. Okay. So when we look under microscope here, actually this is resemble the normal bony structure. They have this is a bony trabeculae with the in between is a marrow spaces. So this is osteoma. Okay. Okay, how we classify malignant tumor is similar for mesenchymal tumor. We add on the word sarcoma at the end of the cell of origin. Okay, for example, chondrosarcoma is a malignant mesenchymal tumor arise from the cartilage. Fibrosarcoma is a malignant fibrous tumor, and the last one, osteosarcoma, is a malignant bone tumor. Okay, so epithelial tumor is a bit different. Okay. So we still add on the words carcinoma, okay, but then we need to look at the histology, how the malignant cells, the arrangement of the malignant cell or differentiations of the malignant cells. Okay, when the malignant cells forming glandular structures, we see as a adenocarcinoma. Okay, squamous cell carcinoma, we need to see the squamous differentiations, like we need to see the keratin pearl, we need to see the individual keratinizations. That all indicates the squamous differentiation. When the tumor, we can't see any differentiation towards squamous cells. There is no any glandular structure formations. So we call as a undifferentiated carcinoma, meaning there is no differentiation into anything. Okay. All right, the examples of the squamous cell carcinoma of the skin. This one you can see grossly. So from the gross also we know this is a malignant tumor by looking at the first, the age of the lesions is very infiltrative. Okay, the hemorrhagic necrosis. Then we look on histology here. Here the tumor actually they have the first we need to know is it any differentiations or not. So here we can see this is a keratin pearl. Okay, this is a keratin pearl, a lot of keratin pearl. So we have the evidence of squamous differentiation. So this is a squamous cell carcinoma well differentiated. Why we say is carcinoma, because these malignant cells already infiltrates in the stroma, meaning they have already disrupt the basement membranes. Okay, this one again a colectomy specimen is different from the previous specimen just now. This is a tumor because we can see it's fungating, right? It's already infiltrate into the adjacent colonnade tissue. Then we're looking on the histology. Actually, this tumor forming glandular structure. but the gland here is complex gland, elongated, they have small gland, there has a big dilated gland, is different from the normal colonic gland, all similar in size and shapes. Okay, when we look on closer the individual tumor cells, it shows all the neoplasia. We will discuss this later after this. Okay, all right, this one another examples. Actually, this is resected tibial. Okay, this is a tumor already infiltrate into the adjacent soft tissue. So, because when we see grossly, we need to make it differential. Is it benign or malignant? Okay, so this is a malignant tumor. So when we look on histology, so this all the malignant cell, we can't see any normal bony tissue like in the previous case just now osteoma. We can't see any bony trabeculae. We cannot see any mirror species here. It's all composed of malignant cells. Okay. All right. That's the very straightforward how we give name for the tumor, mesenchymal epithelius. So they have exceptions for other tumor. Okay. The third categories is tumor with mixed differentiation, meaning that okay, just now epithelial tumor is a any tumor arise from the epithelial cells. Okay, for the mixed tumor, meaning this tumor they have two components. They have the epithelial component plus the mesenchymal component. Okay, the benign part is a pleomorphic adenoma of the salivary gland. They have the mesenchymal plus the epithelial component. Carcinosarcoma is the malignant tumor composed of carcinomatous element and sarcomatous component. Okay, the fourth category is teratoma. Okay, teratoma is a tumor comprises of cells from more than one germ cell layer. As you know, we have three germ cell layers, right? When the tumor is around more than one type of this germ cell layer, we call as a teratoma. Okay, the most common examples is benign cystic teratoma of the ovaries. I will show you the picture later. Okay, here. So this is a ovarian tumor. Okay, you can see grossly, we can see this is hair follicles, is a hair. Okay, this is a bone actually. This is sebaceous materials. When we look on histology, they have all the three germ cell layers. Okay, this one we can see thyroid follicles, we can see smooth muscle, we can see the salivary gland. This is respiratory components. So they have the at least two component of the germ cell layer. But this all component must be matured. That's why our final diagnosis is matured cystic teratoma. Okay, matured cystic teratoma is a benign tumor. If we find out there are immediate component, it's already become malignant. Okay, so we need to sample extensively to find any immediate component because it's defined the further treatment of the patients. Okay, so it is a pleomorphic adenoma of salivary gland. Okay, actually this is the normal adjacent salivary gland tissue. This is the tumor. Okay, we can look on his gross specimen. The age of the tumor is well circumscribed, is regular, and also the sections, the cut sections, homogeneous surface, all whitish color, no hemorrhage, no necrosis. This one all features towards the benign morphology, okay, on grossly. So when we look on histology here, we can see this is the mesenchymal component, this is the fibromyxoid stroma, this is the epithelial component because this tumor forming glandular structure. So they have both component, okay. So this is a benign pleomorphic adenoma. Okay, these are the last categories. Actually, aberrant differentiations is not true neoplasia. On clinical, okay, we can see a nodules or lesions. Okay, sometimes we misdiagnosed as a neoplasia. Okay, they have two terms here, hamartoma and choristoma. Okay, hamartoma meaning that this is a disorganized mass of tissue whose cell types are indigenous to the site of the lesion. Okay, I will give you example after this. Choristoma meaning they have ectopic focus on normal tissue in the other organs. Okay. Okay, hamartoma meaning, okay, this is sections from the lung. Okay, you can see this is a normal lung tissue. Then you can see one nodule here. Okay, by looking at this node, you grossly, it looks like a benign tumor, right? Because they have the well-defined age, regular age, homogeneous surface. So we think it's a tumor, benign tumor. Okay, when we resect this tumor and look on histology, okay, what we can see is it's all composed of cartilage, okay, fibrous tissue, meaning this component actually made up of the normal lung tissue. Okay, so actually this is a not tumor. Okay, hematoma meaning any normal lung, any normal tissue that present in that particular organ that form a nodules. All right. How about cholestoma? Okay, this is actually a gastric tissue. Actually, this is a gastric epithelium. And then in the stroma, we can see this is actually a pancreatic tissue. Okay, meaning in higher magnification, okay, so this is a pancreatic tissue. Okay, so cholestoma meaning they have some evidence of ectopic tissue from the other organs that situated in that organ. Understand? There's a difference between hematoma and cholestoma. Okay, in medicine only they have exceptions, right? Okay, just now you learn about when we use words oma is meaning benign tumor, but this is not a benign tumor. Okay, hepatoma is a malignant liver tumor. Okay, but the name is quite misleading. Okay, so the other name for hepatoma is hepatocellular carcinoma. Okay, melanoma is a not benign tumor. Again, it's a malignant skin tumor. Seminoma is not also benign tumor. It's a malignant testis tumor. Lymphoma is a malignant lymphoid tumor. Okay. All right. Next, we're moving on to the characteristic of benign and malignant neoplasm. How we distinguish between these two? Okay, they have a few criteria here. First, differentiations and neoplasia, rate of growth, local invasions, and last one, metastasis. Okay, we'll look one by one. Okay. Okay, for differentiations, what do you mean by differentiations? Differentiations meaning that the neoplastic cell resemble the corresponding normal cell, meaning how the neoplastic cell looks like similar to the normal cells. That's the simple words for the differentiations. Okay, anaplasia meaning there is no or lack of differentiations. Okay. So for differentiation, just now you know the meaning. So we can further classify into well differentiated to poorly differentiated neoplasm. Well differentiated meaning this tumor is similar or resembles to the cell of tissue origins. Poorly differentiated meaning this tumor is not totally different from the tissue of origin. Sometimes we can't see any differentiations. Okay. We need staining to know what is the cell of origins. Okay. Sometimes we can't see any differentiation. So as I mentioned to you, we use the word undifferentiated or anaplastic tumors. Okay, the correlation between with behavior, biological behavior. Okay, for benign tumor, normally they have the well differentiated, meaning when we see benign tumor on histology, they similar as a normal tissue. Okay, poorly differentiated malignant neoplasm, they have a worse or poor prognosis. Okay, this example here we can see actually this is hysterectomy specimen. Okay, this is a uterus. We can see this one all the fibroids. Okay, this is a benign tumor because the age of the tumor all looks very regular age, and the sections is homogeneous, no necrosis, no hemorrhage. Okay, so this is a multiple fibroid. Okay, when we look on histology here, again, we can see the age of the tumor is circumscribed, okay, not infiltrate into the adjacent myometrium. On higher power, okay, this is the how smooth muscles, okay. Okay, leiomyoma is a benign tumor arise from the smooth muscles. Okay, this is how the smooth muscle looks like. This is how the leiomyoma looks like, okay, or fibroid looks like. It's very similar, okay, meaning they have the spindle shapes like in the normal smooth muscles. They have there is no evidence to say points towards malignancy, like all the tumor cells doesn't have any pleomorphic nuclei, all the signs of anaplastic looking cells. Okay, we will discuss later after this. All right. Okay, anaplasia. Okay, I will keep on saying anaplasia. What's mean the anaplasia is lack of differentiation. When we want to see anaplasia, we want to look at the morphological changes. What are the morphology changes? For one is a pleomorphism. Okay, the pleomorphism meaning that the tumor cells, they have the variations or varies in the size and also the shape. They have the very big size, they're the smaller size. Sometimes the shape also varies in shape. That's the definition when we say as a pleomorphism. Okay, abnormal nucleus. Okay, next we see at the nuclear features. Okay, the nuclear features we can see hyperchromatic, meaning the nucleus become very dark colors, and then the size of the nucleus is more than cytoplasm, because in normal cells the cytoplasm must be more than nucleus. Okay, and the chromatin become clumping, and we can see prominent nucleoli, right? The third criteria is mitosis. Okay, mitosis. Okay, for both benign and malignant tumor, we can see mitosis. Okay, mitosis doesn't mean it's a malignant, but for malignant tumor, the mitosis rate is more increased. And also we can see the morphology of mitosis is atypical and bizarre mitosis. Unlike in the benign tumor, the mitosis is a benign or as a normal mitosis. Okay, the shapes of the mitosis. So we need to know what's the normal shape of mitosis, what are the abnormal shape of mitosis. Okay, loss of polarity meaning the arrangement of the cells is already haphazardly arranged. Okay. All right, this is the examples of anaplasia. Okay, this is tumor cells. Okay, you can see here this is the individuals of the tumor cells. When we want to say it's anaplasia, when we look at the nuclear features or morphology of the individual cell, first one they have the pleomorphic nuclei, right? So pleomorphic, we can say these cells, they have the varies in the size and shapes. Okay, then the chromatin pattern here is dense hyperchromatic clump, and here in I saw here this is very prominent nucleoli. So this is mitosis, is abnormal mitosis here. Okay, this again here, this is all the abnormal mitosis. Okay, we can see the shapes of the tumor cells is varies. Okay, so variable. Right. Okay, dysplasia meaning is a abnormal growth. Okay, when we want to say dysplasia is only accounted principally in the epithelial lesions only. Okay, so it's characterized by the changes in the individuals and also in the architectural orientation of the cells. Okay, but dysplasia is not a malignancy yet. It's a precancerous lesion before developing into malignancy. Okay, dysplasia. Okay, for example, in dysplasia, we can see in the ectocervic and colonic polyps. Okay, so when we say it's a dysplasia, further we need to grade them. Is it low grade or high grades? Okay, because this one they have carried different treatments. Okay. Normally for high-grade dysplasia is often classified as carcinoma in situ, because for high-grade dysplasia is already involved the full thickness of the epithelial lining. Right, this example. Okay, actually this is station taken from the ectocervic, because ectocervic is lined by this is stratified squamous epithelium. This one how the ectocervic normal looks like. Okay, you can see this is the basal layer, and when there is when we approach the surface area, the cell become more matured. So meaning we can see in the surface, the nucleus become more smaller compared in the basal areas. Okay, let's compare in these pictures. Okay, this is a normal ectocervic. So here you can see the dysplastic areas. Why we call this is dysplastic? Because these cells, first one, the arrangements already disorganized. Compared to here, the arrangement of the cells is in a is very the arrangement is orientation is in the basal areas. Okay, the all architecture of the cells is similar. Okay, but here he haphazardly arrangement. Okay, and then we can see there is no maturation toward the superficial. We can see the alignment of the cells in the basal area towards the superficial. Okay, so meaning that this whole full thickness is comprises of the dysplastic cells. Okay. That one is a high-grade dysplasia. Okay, similar like this one also ectocervic. Okay, this is occur, the dysplastic area is in the middle thirds, okay. In the second third, in the lower and the second thirds, and in the upper, the surface is still normal. In next pictures, this one dysplastic area already involved in the full thickness of the epithelium. So this one is a high-grade dysplasia, okay. All right. So next features is rate of growth. Okay. The rate of growth is determined by the first one doubling time of tumor cells. Okay, tumor cell is similar like a normal cells. They have the they also enter the cell cycles. Okay, so the estimated original transformed cells must undergo 30 population doubling to produce this one at least 1 gram. 1 gram is a minimal size that we can see tumor clinically. Okay, this is the minimal the minimal size that we can appreciate tumor clinically, about 1 gram. Okay, after 30 population doubling, and then the second factors is fractions of tumor cells in the replicative pool. I will show you pictures after this. In study, they said about 20% 20% tumor cells in the replicative pool, meaning that is more in the non-replicative pool. They have the significant. After that, I will tell you. Okay, and then the rate of which tumor cell are shed or lost during through apoptosis and maturations. All right. Okay, let's look this diagram. Okay, this meaning by this is proliferative pool. This is a non-proliferative pool. Okay, proliferative pool meaning all the tumor cells still in the cell cycles. Okay, when they enter the G naught, it's already entered the non-proliferative pool. But the mainly tumor is in these areas. Okay, about 80%, only 20% here. But as you know, our chemotherapy agent mainly works at the proliferative pool. That's why the tumor need to resect first. Usually, normally we will resect the tumor, and then what happened? The remaining tumor will enter in the proliferative pool, and then we can give chemo to kill all the tumor cells. That is basically the theory lah. Okay. All right. Next one, local invasions and metastasis. For benign tumor, it can grow as a expansile masses, but it's not infiltrates into the adjacent structure. Why? Because in the benign tumor, they still have the capsule, they still have the intact basement membranes, so they can. That's why it's remain localized, and they do not have the capacity to infiltrate or invade into the other structures. Right? And also for benign tumor, it's grow and expand slowly. Okay. For malignant tumor, because of the basement membranes already destroyed, they doesn't have any capsule, so this tumor can easily progress or infiltrate into the adjacent structure, and also can metastasize to other organ. That's why in the gross specimen we can see the age of the malignant tumor is poorly circumscribed. They have ill-defined or infiltrating margin. All right, they can develop metastasis to the distant organ. This is basically a diagram to show you how we distinguish between benign and malignant tumor. So benign here we can see they have capsule. Sometimes even though they didn't have capsule, but the basement membrane here still intact. Okay, whereas in the malignant tumor, it doesn't have capsule, and also the basement membrane already destroyed, so they can go again anywhere. Right. Okay, these examples. This is sections from the breast tumor. Okay, by looking at the gross morphology, when we assess, we know, we can say this is a benign. Why? Because the age, because how we describe the tumor grossly. First one, we need to look at the age, either irregular or regular. We look at the sections, okay, either homogeneous and not homogeneous. They have necrosis, hemorrhage, okay. So in histology, we can see this one. Okay, they have two components. Okay, fibroadenoma, they have two components. Mesenchymal component here, this one the fibromyxoid stroma, and they have the glandular component. But then the glandular component all lined by the double-layered epithelium, similar as a normal duct and acini in the normal tissue, in normal breast tissue. So it is a benign fibroadenoma, benign breast tumor. Okay, this is a mastectomy specimen. So you can see grossly the age of the tumor is already infiltrative, right? So this is the middle, they have a necrosis. So we know it's a malignant. When we look on histology here, this tumor is forming glandular structures, but then this glandular structure only lined by one single layer of cells, okay? So this is, we say, is a malignant cells because they already lost the myoepithelial cells. Okay, they doesn't look like a normal breast tissue, and also they doesn't have the myoepithelial lining, only lined by a malignant cell or this one malignant cells. And when we look at the individual tumor cell, they have all signs of anaplasia. Okay, to invasive carcinoma. This one again, this is a specimen from the liver. Okay, this we can still see this is the remaining normal liver tissue. So we can see there's a lot of multiple tumor. Okay, this tumors or the tumor when we look on histology. Actually, they have a malignant tumor forming glandular structures. It's a metastatic carcinoma. This is the residuals hepatocyte. Okay, this is central veins. Okay, this is diagram just want to show you the difference between benign and malignant features. Again, in benign, the rate of growth is slow. Okay, mitosis is few but normal form. Malignance is variable. They have frequent mitosis with abnormal form. The differentiation in benign is well differentiated, meaning it's similar to their cell origin. Whereas the malignant tumor, they have a polydifferentiators or anaplasia. And local invasions in 9 in benign, malignant, the infiltrative metastasis not occur in benign, can occur in malignant tumor. All right. Okay. The third subtype is a carcinogenesis. Okay. What is carcinogenesis? Is a multi-step process resulting from the accumulations of multiple genetic alterations that collectively give rise to the transformed phenotype. This is the full definition from the textbook. Okay, right. So they have three processes involved in the carcinogenesis. First one, initiations, promotions, and propagations. So we look one by one. Okay, initiation meaning that basically in the carcinogenesis, it started from the one normal cells. Okay, this one stable or one normal cells, okay, must go it must be changes. Okay, its changes arise spontaneously or induced by exposure to any carcinogens. Okay, and then what happened, the cellular genome undergoes mutations and they will create the potential for the neoplastic developments. And then the human DNA sequence responsible for this transformation is called as a oncogenes, right? That's the first step. Then the second step is, okay, just now the normal cell already transformed, right? Because of the genetic events and genetic damage or DNA damage. Then what happened to that transformed cells? So it will, it either can be harmless, or when the mutations is keep going, continuously going. So what happened, they can stimulate to undergo further proliferations and lastly develop tumors. Okay, all right. This one progression meaning when they have the repeated exposure to the carcinogenetic stimuli, they can increase the malignant transformations. All right. Okay, this is the process. Basically, the diagram show you carcinogenesis process. So it start with the initiations, came from the cell, normal cells must go DNA damage first. So from by the oncogenes, when the continuous of the damage, okay, continuous of the stressor, and then they keep on proliferating, and last one transform into the malignant tumor. In this stage, they have the angiogenesis for the tumor to grow. Okay, they can cause the invasions and metastasis into the adjacent structures. Okay. So this is a two cancer gene that you need to know, oncogene and anti-oncogene, or the other names is tumor suppressing genes. Okay, sorry. So oncogene is a positive regulator of carcinogenesis. Okay, in the non-transformed cells, they are inactive, or we can call as a proto-oncogenes. Okay, gene mutation can activate these proto-oncogenes and resulting to transform into oncogene. For example, the oncogene is RAS, occur in the lymphoma buckets, and they can closely related into different type of cancer. Okay, anti-oncogene, or the other name is tumor suppressor gene. Okay, and basically the name is anti because they have negative growth regulator. Okay, in the normal genes, okay, the functions of anti-oncogenes is to suppress or regulate cell proliferation. Okay, but when they become mutated, can cause promotes in the carcinogenesis. Examples is RB genes and P53 genes. Okay, this is the examples of oncogene and tumor suppression genes. I think this one you can read by yourself. The most common make lymphoma for tumor suppression genes. APC, this one as in the colorectal cancer. Okay. All right, what other factors influence the cancer development? It can be divided into intrinsic factors and extrinsic factors or external factors. For intrinsic factors, age, hormonal status of the individual's family history, genetic predispositions. For the external factors, includes diets, lifestyles, individual habit, for example, smoking, alcohol abuse, chemical radiation, and also infections. Right. The last topic is clinical aspect of neoplasia. Okay, for both benign and malignant tumor may cause problem. Okay, first due to locations and impingement on the adjacent structure. Okay, for example, in the brain, even though it's a benign tumor, it can cause a serious complications of the patients, unlike in the others organs, because in the brain, in the brains, okay, because it is a confined areas. Okay, when, for example, in the tumor is quite big, it can cause a very serious serious consequences, even though it's a benign. Okay, because of the locations of the tumor. Okay, the second one, functional activity, such as hormone synthesis or developments of paraneoplastic syndrome. We'll discuss further after this about the paraneoplastic syndrome. Bleeding and infections when the tumor ulcerated through the adjacent structures. Symptoms that result from the ruptures or infections, and last one can cause the cachexia wasting because of the loss of weight and loss of appetite of the patients. Okay, paraneoplastic syndrome. Okay, this is disorders that are triggered by the altered immune system respond to a neoplasm. Okay, basically, paraneoplastic syndrome is a clinical syndrome involving non-metastatic systemic effect, meaning it's not related to the metastatic. It's not related to the effect of the tumors. Okay, non-metastatic systemic effect that accompany malignant tumor. Okay. This is examples of the paraneoplastic syndrome. The most common is Cushing syndrome, occur in case of small cell carcinoma of the lung because of the ACTH or ACTH-like substance will secretes the cortisol can cause the Cushing syndromes. Okay, this one, the rest you can read by yourself. And then last one, how we grade and stage of the tumor. Okay, you need to know the difference between grading and staging. Okay, grading is histology or morphology features. Okay, the staging is histology plus the clinicals. Okay, so grading basically will look at the degree of differentiations of tumor cells in some cancer and the number of mitosis architectural features. This is what we saw when we want to grade any tumors. Okay, so they have two categories, either low grade or high grade. This is the simple way of how we grading, but each of the tumor they have their own grading system. Okay, for example, Bloom-Richardson grading system is specifically for breast carcinoma. Gleason grading is for prostate carcinoma. All right. Staging. So staging basically they covered the size of the primary tumor. the extent of the regional lymph nodes involvement, and also present or absence of metastasis. Okay, for us, we use the T and M staging. T is stand for the size of tumor, N is for the nodes, and M is for the metastasis. Each of the tumors, they have their own T and M staging. Okay, it is not similar. Okay, this one, the examples of breast carcinoma, this is how we grade histologically for breast carcinoma. We use the Bloom-Richardson grading. So basically, we'll look histology into three components. Okay, first we look at the architectural, the tubule formations, we grade it, and then the third one we look at the nuclear features, and the last one we look at the mitotic count. Okay, and then we scored each of the categories. Okay, each of the category, they have three, the highest score. Then we add on all the three categories. Then we further grades based on that. Okay, this is examples of TNM staging for the breast carcinoma. What we use here, the T and M. I think that's all. Okay. Any question you want to ask before I move to the next lecture? Diagnostic histopathology. Anything you want to ask regarding neoplasia?
Assalamualaikum, Dr. Jen. Haris ya. Dr. Jen ada anaplasty. Is it reversible if you remove the trigger, the insert agent?
Sorry, yeah, I cannot get. Anaplasia, okay.
Anaplasia, is it reversible if we remove the insert agent?
Oh, okay. Before that, before I answer your question, you need to understand the difference between anaplasia and dysplasia. Okay. Yeah, anaplasia. Okay. I'll try look at the this one. Right. Anaplasia. Okay, anaplasia will look at the morphological changes. Okay, anaplasia is a sign of a malignancy. Okay, anaplasia is occur in the malignant tumor. All right. Okay, so when we see anaplasia, it's a malignant already. Okay, so meaning even though you remove all the stimuli, it's already malignant, so you cannot do anything. Understand?
Okay. Anaplasia is not a cellular adaptation to the stress lah.
No. Cellular adaptations of the cell, they have four only. Okay, cellular adaptation, they have four categories only. They have the hypertrophy, hyperplasia, they have atrophy, metaplasia. It's not anaplasia. Anaplasia is malignant. Understand? Okay, the cellular adaptation only four. Just now what I mentioned to you lah. Okay, the four cellular adaptations, any stressor, when you stop the stressor, they can revert back to normal physiologically and physically. Okay, understand? It's not anaplasia because anaplasia is all the, when we look at all the features, it's all points toward. Is it answer your question?
Yes, doctor. Thank you.
Dr. Shaza here, I'm one of the surgical postgraduate in one. I have a question regarding neoadjuvant chemotherapy. So, can you actually get the grade to go down, as in to improve, if you know what you get what I mean? So post neoadjuvant, or is it just the size, or what sort of changes do you expect? Would you see if you give neoadjuvant?
The one I think your suggestion I'm not really familiar with the treatment, but basically what I know in the theory, okay, when we look at these pictures just now, and I show you one diagram just now, okay, hold on, see. Okay, so di atas. This one. Alright, basically what we know in the theory. Okay, basically this what we know in the theory lah, what they describe in the book. Okay, because you know the tumor cells is similar like a normal cell. They need to go undergone into the cell cycles. Okay, basically in the cell cycles they have two areas, proliferative pools and proliferative pools. Okay, so proliferative meaning the cells keep on going, so meaning is in cell cycle. This is when we entered the genoid, is a non-proliferative pool. But in the study, they said mostly the tumor cells is in the non-proliferative pool, about 80%, only 20% in these proliferative pools. So they said that because of that study, so because our chemotherapy mainly the target in the cell cycles. When the tumor cells is mainly in the non-proliferative pool, when we give chemo, it's not really works well, right? So that's why we need to excise the main tumor first, and then the remaining tumor, so they can, from the genoid, they can enter the cell cycles, so we can give further chemo to kills all the remaining tumor cells. That's the theory that we understand. Okay, for new adjuvant that you mentioned just now, for new adjuvant, they give chemo first, right? Because sometimes what I know, like, I really have very little knowledge about that. Okay, what we know that because of the size of the tumor is very big, we want to shrink the tumor, so we give the chemo first, and then we proceed with the resections. After that, we also can continue with the chemotherapy. I think for further details, that one you can ask surgeons to answer your question. Sorry. Okay.
Is there any other question from the floor for the first lecture? I think there is no questions. Dr. Zana, anything you want to add for the first topic for neoplasia?
Okay, for the neoplasia, right? For you all. Okay, I think the most important that you need to know is a bit about the nomenclature definitions. Is you need to know definition. But the most important thing is you need to know how we distinguish between benign and malignant tumors. Okay, grossly, and also because the gross is most important for you when you do the surgery. At least you know it's a benign or malignant grossly. Okay, and then the carcinogenesis, a little bit about carcinogenesis. You need to know what are the most common carcinogenesis that are very well established. For example, in colorectal, right? They have very carcinogenesis is very important for you. All right. That's it.
Dr. do we need to know details on the morphological on microscopic view?
No, I think for you all, at least you can differentiate what is adenocarcinoma, what is squamous cell carcinoma. That's the main. The rest, the anaplasty, undifferentiated is not your level lah. Meaning at least you know adenocarcinoma is the malignant tumor forming glandular structures at the definitions, right? The squamous cell carcinoma is a tumor that have the squamous differentiations. For you all, at least you know how to differentiate between that two.
Alright, thank you, Dr. Zana. Can we take a 5 minutes break before